indications, be it treatment of thrombosis or prevention of thrombosis, atrial fibrillation, and interestingly, Europe, which has much more restrictive approvals for these medications, the European Medicines Agencies have approved rivaroxaban in patients with acute coronary disease as well. I'm hoping the slides come up quickly, and maybe we can, yeah, there you go. Thank you. Okay, so quickly, going through this one, I think you saw until here, and then that's where I was telling you that within those 7 to 8 years, there was 4 new direct oral anticoagulants that were approved. And then in 2015 came the idarucizumab, which is a monoclonal antibody that is a specific reversal agent for dabigatran. Then last year, sometime in fall of last year, 2017, betrixaban was approved. And then now we are looking at probably sometime soon approval of another antidote, specifically for the anti-10A direct oral anticoagulants. So quickly, before we go any further, just in 10 seconds, I wanted to show you how the different anticoagulants work. Heparin, as we know, it's an indirect thrombin inhibitor. It activates antithrombin 3, and antithrombin 3, when it's potentiated, will block the thrombin, and that's how it works. Vitamin K antagonist works on 4 coagulant proteins, 2, 7, 9, 10. Direct thrombin inhibitors, as the name says, it directly blocks the thrombin. And then factor 10A inhibitors, as the name says, it specifically blocks activated factor 10. So what's the difference between these DOACs? So before we talk about the DOACs, let me clarify a little bit. And there was a lot of confusion in terms of the nomenclature for direct oral anticoagulants. Ultimately, ISTH, the International Society for Thrombosis and Hemostasis, a few years ago came up with a standardization for the nomenclature, and they now say that we should be using DOAC. People used to call SOACs, TSOAC, target specific oral anticoagulants, then new oral anticoagulants. These are not new or novel anymore. Somebody was calling ODI, oral direct inhibitors. Somebody were using SODA, specific oral direct anticoagulants. But in general, now there is a consensus that we should be using DOACs as nomenclature for all these newer drugs, direct oral anticoagulants. So these are the 5 drugs that are now approved and available in the market: dabigatran, rivaroxaban, apixaban, edoxaban, and betrixaban. So looking at, there are some nuances, there are some specific differences, and this is a table that we don't have to go in detail of all the things, maybe a cheat sheet when you're actually talking to somebody or you're explaining what the nuances are for you. If you want to, if somebody, if they're medical students or fellows who have to take boards, this is the slide you want to look before the day of your exams. So the main thing, bioavailability is an important thing. And I highlight this and I point this to patients and also people who prescribe. As you can see, dabigatran has very low bioavailability. It's only 3 to 7%. Dabigatran is a capsule, and rest of them are all tablets. For whatever reason, if somebody breaks the capsule or chews it or something like that, if it's opened, the bioavailability increases by 75%. So that's something that you should tell them. Don't do that with dabigatran. The rest of them have very good bioavailability. You can see that it ranges anywhere from 50 to 100%. Rivaroxaban probably having the highest, close to 80 to 100%. The second thing is, the important thing that you need to realize is the half-life. These medications have rather short half-lives. The longest one among these 4 is dabigatran, which is about close to 18 hours, 16 to 18 hours. And then edoxaban is about 10 to 12 hours. Apixaban is about 8 to 12 hours, and rivaroxaban about 6 to 8 hours, sometimes up to 10, particularly in elderly people or if there is some interaction with other medications, which we'll talk about in the next few slides. The next important thing is, how are these medications excreted? Dabigatran almost exclusively depends upon renal clearance. Almost 80% of the drug is cleared by the kidney. So that kidney function is something very, very important in patients who are on dabigatran. Not so much with rivaroxaban, only about 30% or so. Same thing with apixaban, 27%. So, elderly people who are on other medications have mild kidney dysfunction, I think apixaban becomes a little more safer to be used. Dialysable, none of the anti-10A drugs are dialysable. Only dabigatran is dialysable. We'll talk about this when we come to the reversal of the coagulopathy from these medications. And then finally, something that we kind of ignore many a times, thinking that these medications don't have any interaction. That's actually not true. You know, when in our current day and age of practice, we have a lot of medications which are dependent on these metabolic pathways, P-glycoprotein, and then CYP3A4. And as a matter of fact, when I was curious and looking at these medications which depend on these pathways, it's long, it's really long. The takeaway is, I'm not saying that you should be concerned about those interactions, but it's a good practice whenever you prescribe to quickly look at what the patient's medications are and identify if there are some really potent ones that would interact with the DOACs. And I have a list that I'll show you in just a little bit. So what are the advantages of DOACs? Rapid onset, short half-life, so you can probably have a rapid offset of the medication. Predictable pharmacokinetics, that's why you don't have to monitor them regularly. Fewer drug interactions, but it's not no drug interactions, it's fewer drug interactions, which is important. And then, you don't have to need to monitor these frequently, unlike warfarin. The disadvantages, difficult to monitor compliance, and compliance becomes a key. Say, for example, apixaban, it has to be taken twice a day. If somebody misses it, one dose, I think their coagulability or whatever the indication that they're on, the risk goes higher. So compliance becomes a big issue. Unlike, say, Coumadin, if you miss a dose, probably your INR is still in the therapeutic range and it can catch up the next time. The second point is no reliable clinically available blood test to determine the drug levels. At research facilities, even at Mayo Clinic, we do have some techniques where we can measure the level of the DOACs in the blood, but that's not very practical. It takes longer time. It's not universally available. So you don't have a quick way of knowing what the level of the drug is in the blood. The drug accumulates with renal impairment. So every time you see the patient, it's important to make sure that their kidney functions are doing okay. And there are no specific antidotes. That's not, it's not a contraindication or a major concern. We can still reverse the coagulopathy. The only thing is you don't have a specific drug that can quickly reverse the anti-10A DOACs. We do have one for dabigatran, the direct thrombin inhibitors. So choosing the right anticoagulant for the right patient, we're going to quickly go through this. There's a lot of data. There's a lot of clinical trials being done. Obviously, with so many of them, there have been several meta-analyses. These stand out as the standard meta-analyses for the DOACs. Now, this meta-analysis was published in 2014 for the clinical trials looking at patients with atrial fibrillation. You can see that the forest plot favors use of back in 2014, there was no standardization, so they used the term NOAC, oral anticoagulants. You can see that the decrease in the stroke or systemic thromboembolic events were much in favor of using NOACs, or the DOACs, sorry. And then looking at the major bleeding events also favors using the DOACs, combining all these studies, the RELY study, ROCKET, Aristotle, ENGAGE, all these clinical trials put together. So the efficacy and safety outcomes, if you look at each of the things, ischemic stroke, slightly better than Coumadin. Of course, much less risk of hemorrhagic stroke with the DOACs. And then when you look at the bleeding, the intracranial hemorrhage was so much lesser with DOACs. The GI bleeding, interestingly, was a little higher, and this was only in the clinical trials for atrial fibrillation, whereas in VTE, it was actually the opposite. So here is the combined meta-analysis of patients, the clinical trials looking at the DOACs in venous thromboembolism. And similar to atrial fibrillation, the combined analysis shows that it does favor, maybe even a little less likely compared to the atrial fibrillation studies, but it does favor using DOACs. This is for the major bleeding events, and there is no cross-comparison trials between one DOAC to another, but what you can see here, the AMPLIFY study, which was mainly looking at apixaban, showed much higher safety compared to the other DOACs. So that might be another reason why we use more apixaban frequently compared to the other anticoagulants. Then again, looking at the safety and efficacy outcomes, similar results, but unlike the atrial fibrillation studies, which showed a much higher incidence of GI bleeding, that signal was not seen in the VTE clinical trials. All right, so this is another thing which is essential, particularly if you're depending on the insurance approval of these medications. We do end up in certain situations with getting the approval of these medications being a challenge. So knowing what are the FDA-approved indications for DOACs is something important. Dabigatran is something that's been approved for prevention of stroke and thrombosis in patients with atrial fibrillation and also VTE. And you can see most of the anti-10A drugs are also approved for both the indications. This is what I was referring to earlier. European Medicine Agency has approved rivaroxaban for also to be used in patients with acute coronary syndromes. Betrixaban, like I mentioned earlier, its only indication is for patients who are hospitalized and are at a higher risk of developing VTE. It's only indicated for prevention of VTE, not for treatment or in patients with atrial fibrillation. So now the anticoagulant selection with so many options obviously comes more confusion. If it's one, you have if it's two, A or B, it's easy to choose. When you have A through F, how do you choose among those 5 or 6 different drugs? So this is a simple algorithm that I follow in my clinical practice, and things might be changing when next time when I come back for this conference or when I give a talk somewhere else, this might be a little different. Things change fast. As we stand today, if somebody has an acute DVT or PE and has active cancer, or if the patient is a pregnant woman, my preference is still low molecular weight heparin. And having said that,